All right, so today I will be discussing a 42-year-old Caucasian female who is full code. She arrived to her nearest emergency department in the city of Fayetteville, where she had complaints of stroke-like and confusion symptoms. She was quickly then transferred to the Raleigh Hospital for continuance of care. While at Duke, she was diagnosed with viral encephalitis caused by human herpes virus 6 and human virus 6B. Viral encephalitis is an inflammation of the brain parenchyma caused by a viral infection. In this case, it was the herpes. The virus then crosses the blood-brain barrier, and it directly invades the neural and glial cells, causing inflammation that leads to cerebral edema and the neural dysfunction. This clinically manifests as the altered mental status, the stroke-like symptoms, and even seizures. At the time that I was in her care, the patient was stable with no presenting symptoms, and she was halfway ready for discharge. The patient's history consisted of POTS, anxiety, ADHD, chronic back pain, and GERD. When I completed my head-to-toe assessment, the neurological status was ANO times 4. Her lungs were strong and clear bilaterally. Her abdomen was soft, non-tender, and non-guarding. She was passing gas, and she had a bowel movement the day before. When I completed my health promotion assessment, the patient stated that she was active for her lifestyle. She had no tobacco or cigarette use, as well as alcohol, and she when I asked her what her current emotion, she said, "Oh, happy as ever can be." I did feel a slight of sarcasm towards that, but I went on without to complete my assessment. She was able to ambulate and complete her ADLs by herself. When I would ask her when I would do her vitals, she stated that her pain was a 0 out of a 0 to 10 pain scale. I assessed her eyes and mouth, and where I noticed some small red dots on her top of her mouth, she stated, "Oh, those were much worse when I first got here, and they had seemed to be getting a lot better." The patient had a CBC and an MRI when she first arrived to rule out any stroke-like symptoms, and then she was noticed that she had the positive herpes diagnosis from her CBC count. When I was able to have her most of her lab values were normal, and going to the right direction with her WBC. It was a 7.1, which stated that her antibiotic therapy had been working against that infection. Her HbG and her HTC were slightly lower. Her BG was a 10 and her HTC was a 31.5, but it was nothing of a big concern. Her electrolytes were all within normal range when I got her already, and her BUN was a 6, into where I concluded that it was slightly lower due to the impact her body received from that viral encephalopathy. Since she had a positive herpes test, I had to use a nursing diagnosis of risk for infection related to compromised host defense and viral reaction of HHV for my infection and immunity concept. Since it was a new herpes diagnosis, I did notice her make some jokes. I assume that was kind of like a coping mechanism for this new diagnosis, and I placed my number one priority as health promotion with a nursing diagnosis of readiness for enhanced knowledge related to a new diagnosis of human herpes virus and prescribed medication regimen. My priority planning for this patient was to get to know her well enough to see how she learned best and her level of medical education. For my implementations, I first assessed the patient's readiness to learn and her baseline knowledge of her diagnosis and her new prescribed medications. Throughout my first couple of hours with her, I learned that she had 6 pregnancies, 2 of which, all of which failed and ended up having to adopt 2 kids as well. She is married and had mom and husband at bedside. Both were there when she was ready for discharge. I also learned that she had a master's in speech specialist, and my SMART goal for her was that the patient, before discharge, will realize understanding of human herpes 6 and 6B, its potential complications, and the importance of medication adherence. When it was close to discharge, it was agreed that she would be receiving virtual nursing discharge, and so I implemented the action to print out all of her discharge instructions and paperwork so that it would be easy to for her to follow along with the virtual nurse. After she had her visit with the discharge nurse, I asked her if she had any other questions or concerned, and if the nurse had gone over signs and symptoms, medications, things of that sort with her just to verify. And she stated that she had, and that she learned that early signs and symptoms for reaction would be fevers, breakouts in the mouth or private areas, and neural changes. Since my patient was ready for discharge towards halfway through my shift, and I only had one patient, there was not much to delegate for this patient. So I performed almost everything that needed to be performed. We did work with our provider and our virtual nursing discharge as collaboration, as well as having transfer team bring her down to main lobby for her to get in her car and head home. The patient's goal for the shift was met as evidence of her repeating some of those signs and symptoms of early warning signs, and her level of medical acknowledgement with her being a speech specialist. As stated previously, I had put health promotion as my number one concept priority, and then I followed that with infection and immunity as my number 2 priority. I also focused on neurointegrity as my 3rd because of that viral encephalopathy, and I also put perfusion as my number 4th because of the history of that POTS. And then health promotion related to infection and immunity, because teaching about medication adherence, safe practices to prevent transmission, and encouraging early signs of reactivation promotes infection control and further complications. 2 things that I took away from this clinical experience were, number 1, to feel more comfortable delegating. Even though I didn't get a chance to delegate for this, with this patient, I was able to feel more comfortable delegating towards my last 4 clinical shifts. It was really hard for me at first because I was still in that NA mindset from level 1 and 2, and then being level 3 with 2 patients who are more critical gave me more comfortability and how to properly delegate and get the feedback back from the NAs. Another thing that I took away was feeling more comfortable just being in a unit and being myself, and more comfortable being with the patients and around providers. For example, if a provider came in while I was about to do a medication administration, feeling more comfortable saying who I am, what I'm about to do, and if it's okay for me to continue doing my medication administration, as well as if any other person would walk into the room, just feeling more comfortable stating who I am and what I'm about to do. I think those were the main things that I took away from this clinical experience. But yeah, that is all that I have. Thank you very much.